early policy decisions taken in the UK and the US were influenced strongly by models from Imperial College London. And these are the models that they made for the UK. And what they show is in an unmitigated scenario. So in other words, if you have no intervention, no social distancing, no lockdown, what would happen? And they predicted that you'd have very rapid and large epidemics occurring a month or two after the virus was introduced into your infection. And they also predicted that you could flatten the curve and slow the epidemic down by putting in place various social distancing, isolation, and quarantine measures. So we could just take these numbers and apply the per 100,000 population deaths and critical care bed figures to Botswana. But in actual fact, there are major problems with doing that. And one of the main reasons is this: it's the age structure of the population. So these are population pyramids. On the left is Italy, the number of people represented by the bars, males and females, and the age going up from 0 at the bottom to 100 at the top. And what you can see in Italy, and what you would find in nearly all European, North American, and even Chinese populations, is that the majority of the population are quite old. Whereas on the right is the Botswana population structure. And what you see is that in Botswana, in keeping with many African countries, our population is extremely young. And at the bottom of this slide are the death rates from coronavirus, the percentage of patients who will require hospitalization, the percentage who will require critical care, and the overall death rate. And what you can see is that the groups who are at most risk are those in the elderly age groups, 60 years and older. And the younger age groups have very low rates of hospitalization and mortality. And if we look at that older age group, you'll see that in Botswana, actually, we've got very few of those individuals compared to in Italy. So this is likely to have a major impact and should mean that we have much lower hospitalization rates and case fatality rates in Botswana. But what would happen to the patients who don't get critical care, in other words, ventilation? Well, we know that we've got very limited critical care capacity. So this would be nearly all of our patients if we had a very large epidemic. And what about the impact of HIV, TB, non-communicable diseases, and so forth? Well, there's been some modeling work done looking at this, and Botswana actually has quite high rates of comorbidities. The right-hand graph, the bar there, shows the prevalence here, up to 80%, and you can see that a large proportion of our population have one or more comorbidities, particularly in the older age groups. In the younger age group, this is nearly all driven by HIV. And previously, we thought that HIV wouldn't impact things very much, but there's some new and rather worrying data from South Africa now, looking at 12,000 coronavirus cases in the Western Cape, 435 deaths. And what they found were that HIV positive individuals were 2.75 times more likely to die than HIV negative individuals, even those on antiretroviral therapy. And of course, this could potentially have a major impact for us in Botswana. So if we do some models looking at Botswana, what could we expect? I'll run through these quite quickly because they're fairly complicated, but just to give an idea, these are models using Botswana specific age data and adjusting the mortality rates to consider these comorbidities. And these are what they expect to happen if we didn't put in place any mitigation strategies. So this would be if nothing was done at all, which of course is not the case. But if that was what was expected, if we looked at hospital occupancy, we'd see a rapidly progressing epidemic. We'd see between 9,000 and 15,000 hospital beds at peak. We'd require about 3,000 to 5,000 critical care beds at the peak. And we'd be expecting around 200 to 300 deaths at the peak of the epidemic. And these are months at the bottom, and you could see that this would occur about 3 months after the infection was introduced into our population. And to put that in perspective, Botswana has a total of about 5,700 hospital beds and a total of about 100 intensive care beds. So you can see that we would be overwhelmed if we allowed an epidemic to happen here. And in terms of deaths, we could expect, based on this model, between 7,000 to 9,500 deaths from coronavirus occurring quite rapidly if we didn't do anything. The group also modeled what would happen if we put in place social distancing measures. 20% social distancing is fairly minor social distancing, 50% is very aggressive social distancing, and shielding measures where we protect our elderly or vulnerable people with comorbidities by putting them effectively in lockdown. And again, this is a very busy slide, but effectively what I want you to show is that even with social distancing or shielding, we still expect to see quite a major epidemic, and we still expect to see our hospital critical care capacity overwhelmed, basically, in every situation other than those with very extensive 50% social distancing, which isn't really possible to do in the long run. So how do we prevent an epidemic from occurring? Well, here's another model from Imperial College. And in this model, they examined what would happen if we locked down. So their basic projections are almost identical to those from the London School of Hygiene and Tropical Medicine model. In their unmitigated strategy, if we did nothing, the peak hospital bed demand is about 19,000 and about 3,500 intensive care beds, very similar. But here they look at what happens if you institute a lockdown. And this here shows what happens to your epidemic curve if we do nothing. And then these are various lockdown scenarios. If we lock down very early, it's this bronze bar here. This is exactly what Botswana did. And what the modeling suggests is, you can hardly see it, we wouldn't have an epidemic. So with an early lockdown, you would predict that we would prevent an epidemic happening at all. And that's effectively what happened in Botswana. But what happens after you lift those restrictions? Well, we've been lifting our restrictions stepwise from the 7th of May. And what the modeling suggests here is that here's your initial curve. We've locked down, we've prevented an epidemic. But if we lift our lockdown restrictions here, what the models suggest is about 2 to 3 months later, we'll see another second wave of the epidemic. And that epidemic would be almost as large as the first wave. So if you just lift your lockdown restrictions and don't do anything, all you've done is delayed the inevitable. And these are some movement data from Botswana. The gray line shows homes. So you can see that when we institute lockdown, people spend more time at home, and then workplaces, grocery and pharmacy stores, retail and recreation and transit stations. And you can see when lockdown was implemented here on the 2nd of April, very rapidly movement goes right down. But we're here now, and you can see that we're completely back to normal in terms of movement in Botswana now. So those lockdown restrictions really have been lifted in terms of movement. So we're now in a situation where we have to monitor things very carefully and prevent further epidemics from happening. Now, very quickly, just to finish off the talk, I just want to give you a brief note on what's called R0 and what we could expect going forwards. So R0 describes how many people are infected by other people in an epidemic. So in this situation, the R0 is 2. One person infects 2 people, and then one person infects 2 more people, and so on. Now, in coronavirus, it takes about 5 days between each of these infections to incubate and become infectious in the next person in 5 days. And we also have an R0 of about 2.5. So that means each person infects about 2.5 people. So that means in 1 month, you get 5 replication cycles, day 1 to 5, 5 to 10, 10 to 15, 15 to 20, 25 to 30, and so on, which is 2.5 times 2.5 times 2.5, 2.5, 2.5. And that means that in 1 month, 1 case would lead to 244 new cases. Now, if we halve that R0 by halving the number of people that you come into contact with, now you get 1.25 infections on average. And if we look at what happens at the end of 1 month with that, you only get 4 cases. So you see that with social distancing, you can markedly reduce the number of transmissions. And of course, if we isolate cases, if we test people, find cases and isolate them and contact trace them, then we can completely break that chain of transmission. So this is why it's so important to have social distancing, contact tracing, and testing in place. Now, just to end up, it's important to say that R0 is not the same for everybody. Not all COVID patients are equal. And it's now becoming very clear that some people can infect a lot of people. So here's an example from America, where a choir practice attended by 61 patients. There was 1 symptomatic patient at that choir practice. They infected 52 other people during a 2-hour practice. 3 patients were hospitalized and 2 patients died. And it's now very clear that super spreading events and clusters of infection are a very important driver of transmission. And in fact, these events can make the difference between an epidemic starting in a country or not. And good data show in many settings that most COVID transmissions come from a very small proportion of infections. About 9% of cases are responsible for 80% of all onward transmission. About 70% of cases don't infect anyone. And these clusters of infection occur primarily in indoor settings, particularly of crowded and with close contact. And very high-risk situations are religious gatherings and churches, hospitals, family gathering, exercise classes, restaurants, bars and nightclubs, and shared workspaces. And these are the 3 C's: closed, crowded, and close contact. So in terms of next steps, I just want to finish with these final points that I think lockdown is highly unlikely to have led to the complete eradication of coronavirus in Botswana. And we need to be aware that data suggests that very few COVID infections are needed to trigger an epidemic, particularly if there's a super spreading event. Ongoing control measures are going to be required until the vaccine becomes available, and care must be taken to prevent further introductions of coronavirus, particularly from South Africa. The key contact measures are case finding and contact tracing, and we need ongoing social distancing, avoiding these 3 C's: closed spaces, close contact. And healthcare facilities and preparations are essential. So I'll leave it there, Reginald, and happy to take any questions.
Thank you so much, Professor Jarvis. Everybody, round of applause for him. Thank you, Prof. And also, I think I saw a message that was asking whether you will be able to avail all this information, these slides.
Yes, I think this is being recorded as it is, so I'm sure it'll be available afterwards.
But will you be able to provide the slides though?
Yes, yes.
Lovely. All right. Now, before I go to the room, to the people here who may have some questions or comments, I will go to those who are actually online right now. Will request that you be very brief with the questions or the comments that you are going to be sending through. But Prof, can I start it off by asking you this? You were talking about the importance of monitoring. What exactly do you mean by monitoring? You said that there must be continued monitoring. You did mention that the lockdown is not a panacea for COVID-19. What else can be done going forward to ensure that the continued spread of COVID-19 is halted?
So I think there are several things that we can do. So one is being very careful with our borders, of course, and making sure that we're not letting in a lot of people who have coronavirus infection. Measures are already in place to try and do that, but we need to carry on maintaining extreme vigilance with the truck drivers coming in and anybody else coming in, that they're not bringing infection into the country. And just testing at the border is not sufficient because, of course, people it's 5 days from when you're exposed to when you become infectious. So they may have been exposed just a day before they come into the country and become infectious 2 or 3 days later. So as well as testing, I think we need to be ensuring that they're not circulating widely in the country and they're wearing masks, practicing social distancing and not visiting many places. I think we also need to be aware that there may be undetected cases of coronavirus in the country at the moment. And the likeliest way that we will detect those is if people get sick and present to their clinic or their hospital or their local healthcare facility. So I think we need to be very careful about screening and testing everybody with symptoms of coronavirus attending a healthcare facility, and we should have coronavirus easily available throughout the country at all healthcare facilities. And finally, I think we need to put in place some measures to try and prevent any super spreading events occurring and triggering an epidemic in case we've missed cases. And I think that would involve limiting the size of large gatherings, not allowing gatherings of more than 10 people, maintaining a degree of social distancing, encouraging working from home, stopping large events from happening, and of course wearing masks as we're doing.